Welcome, everyone. And since I'm the last one standing between you and our dinner, I'm going to keep it very short and just share with you some of our experience in how to take the cutting-edge technology into clinical setting and trying to see if we can at least realize our dream of precision and personalized cancer medicine a little bit. And so today I'm not going to talk about technology, but just to show you some of our experience, and perhaps we can all work together to make this happen. And so this is some of my disclosure. And so we all know that cancer is the leading cause of death worldwide, particularly in this part of the world. And we also know that this is the treatment that the cost that we spend on cancer treatment. So you can see that worldwide the treatment cost is actually increased every year. But then, how do we spend this money wisely so that most of the money is well spent, not only in the prevention but also in the treatment? How do we incorporate the neurotechnology and also our knowledge into treatment? I think this is some of our experience and also our thinking. So we already know that cancer is a group of genetic diseases. So tumor cells typically will harbor point mutation, some translocation, some amplification, and deletion. And since all of these genetic alterations are mainly the driver that drive normal cells into tumor cells, so within this genetic alteration, there will be some information and also a critical factor that will help us to identify or determine how to treat that patient. The other thing is that since these alterations are mainly tumor specific, so we can possibly also use this genetic alteration as a marker to track patients' tumor, to track patients' recurrence. So these are the idea behind personalized cancer medicine, particularly integrate genetic markers into treatment monitoring and also treatment selection. So I'm going to give you some of the examples that we have in-house in terms of how to use genetic marker for precision medicine. And the next couple of cases will focus on therapeutic treatment. And so I'm not going to spend time on next generation sequencing, but just to tell you that this is a newly developed technology. In using this technology, you can profile a lot of genetic changes using just small amount of DNA. So you can collect samples from patient, and then you extract DNA or RNA, and after that you conduct a targeted sequencing, or you can even go for whole exome sequence. And after that sequencing, you will obtain the data. Then you annotate all of the variant, and then based on the genetic alteration within patient's tumor to determine the treatment strategy for the patient. So it is actually quite straightforward. And so for treatment selection, we typically would not go for whole exome sequence unless we are talking about immunotherapy. So that's focused on treatment selection that typically work on cancer panel. So you can either use a very small panel, for example, BRCA1/2 mutation sequencing, or you can use like a drug panel that containing all of the drug targets. So for example, 35 genes to select treatment option for the patient. Or alternatively, we can also use a larger panel, so a panel that contains 300 to 400 genes to profile all of the tumor-related pathways, and then based on that information to treat tumor. And then, of course, the ultimate treatment, ultimate test is if patient is really desperate, then we can also conduct whole exome sequencing, and based on the somatic mutation and neoantigen to identify freely personalized treatment option. So I'm going to give you some of our experience on how to use a panel that contains about 400 genes for treatment selection. And so this type of treatment selection, at least in our mind, has to take into consideration not just on the mutated genes or mutated targets, but we can also integrate the information on pathway. So it is a pathway-based treatment selection. for the patient. And so typically it will include more than 400 genes also. And we typically sequence very deep. And so we're talking about 800 to 1,000x. And the reason for going for such deep sequences so that we can detect a minor clone. So, for example, mutation can be detected if the mutation allele frequency is greater than 2%. And also, this type of assay typically will be using FFP samples instead of frozen tissues. So these are more available for clinical setting. And then when we analyze the data, we take into consideration of point mutation as well as copy number alteration, and then incorporate all of this data into pathway. And then based on those information, we can determine the treatment option for the patient. And so this is taking all of our knowledge right now on the hallmark of cancer, and then incorporate all of this concept and also use the cutting-edge technology to determine the treatments for the patient. So typically this type of sequence will include a lot of genes, and most of the genes will be focusing on cancer-related signal and pathway. So genes related to cell growth, cell survival, cell death, and migration. And then when we sequence enough genes on individual pathway to detect mutation, to detect copy number, we can integrate all of this alteration and then see how the patient's tumor will respond or will be sensitive to. So the reason for this kind of approach is because for individual pathway, typically there's only one or two drugs available, and the drug target may not be the gene which will be mutated or be deleted. So if we just focus on drug target, if we just focus on sequencing the drug target, we're going to miss the treatment opportunity for the patient. The other thing is that typically for targeted sequencing, if you just focus on oncogenes, then for lung cancer, it's maybe appropriate, but for other cancer type, a lot of mutation doesn't occur on oncogene. Instead, it's a deletion or mutation of tumor suppressor. So those genes will be mutated, but you have to look into where that mutation located and what kind of pathway it will alter, and then based on that information to select treatment options. So let's look at the most frequently observed mutation in patient. Just for the mTOR pathway as an example. So you will see some patient with PIK3 activating mutation. You will see some patient with AKT activating mutation. These are point mutation. But in fact, you will see more often that patient has P10 copy number loss. You will see patient with TSC1/2 copy number loss. You will see patient with, for example, a lot of oncogene amplification. So in order to detect all of this copy number alteration, you do have to have a very well-developed technology in order to detect all of this copy number alteration. So how to take all of this information into treatment selection becomes not just simple sample preparation and then go for treatment. So let's look at the example. So this is a patient with metastatic triple negative breast cancer. So she's 50 years old. When she was sent to us, when her sample was sent to us, she's stage 4 with bone and liver meta. And I have to admit, all of the sample that I'm going to present, all of the cases that I'm going to present today are heavily pretreated cases. So far, we don't have any case that are newly diagnosed or even stage 1-2 patient. So we're just trying to see how we can use cutting-edge technology to help this patient. And so these patients are typically already run out of standard of care option. So we get the patient's sample from breast. So this is FFP core-needle biopsy. We conduct a 400 gene test for the patient. So this is what we observed. So for this particular patient, if we look at all the genetic alteration on those 400 genes, these are the mutated genes, and so the only what we call actionable mutation is this AKT1 activating mutation, E17K. And if we look at the patient's copy number profile, then this is upper part is patient's blood sample, and the bottom part is the patient's tumor sample. This patient actually has a very stable genome. So this is quite different from the next two samples that we'll see. So for this patient, if we put all of this data together, then the only option is the AKT1 activating mutation. And this is not a rare case. So AKT1 activating mutation occur in about 6% of breast cancer patients. And because AKT1 right now, still no approved targeted therapy. So instead of trying to enroll the patient into clinical trial, which is not available in Taiwan, we put this data onto pathway, and you can see that AKT1 is actually one of an oncogene which located in the mTOR pathway. And so with an activating AKT1, we anticipate that mTOR activity will be elevated for this particular patient. And so for that patient, the only available treatment, targeted therapy at that time, is mTOR inhibitor. So we recommended at least to include either oral or maybe injectable mTOR inhibitor into the patient's treatment selection. And so the oncologist actually took our recommendation, and the patient agreed. So the patient was put on mTOR inhibitor initially on oral formula, and later on injectable formula, and then switch back to the oral formula. And so the patient actually experienced a stable disease for quite some time. And so when so the CT scan 3 months after on mTOR inhibitor, we can actually see partial response on this particular patient. So stable right breast met tumor and bone meta. And then so initial response was quite well, but the patient was actually at that stage is actually quite later stage. So she was on this treatment and with stable disease for at least 3.5 months before the patient was put on palliative care. So this is this is the first case that we tested in our clinical patient. So we're actually quite encouraged. But if we just rely on activating mutation, then the chance for patient to be treated is quite limited. So this is a different case. So this particular case is a patient with metastatic breast cancer, actually hormone positive and HER2 negative. So again, she's stage 4, and this is her prior treatment history. So again, the patient already ran out of option. So when we get her FFP sample from soft tissue, and this is the particular, so on the right-hand side, this is the sample, that the section that we use for sequencing. So our pathologists estimate that there are about 75% of tumor in this particular tissue. And within this particular sample, we only detect one activating mutation, which is actionable. This is the PIK3E505K mutation, and about 20% of mutation allele frequency in this particular tumor. But in addition to the point mutation, we also found that the patient has some copy number alteration. And again, this particular patient, the most interesting copy number alteration is MCL1 amplification, as well as a lot of tumor suppressor also heterozygous deletion. So if we look at the treatment option and then map all of those genetic alteration onto the pathway, then you will find that for the mTOR AKT pathway, activating mutation occur at PIK3, and also a lot of downstream tumor suppressor are deleted on the pathway. So that means this patient could theoretically benefit from drug that targeting mTOR pathway. But in addition to the mTOR pathway activity, we also found that patient has MCL1 amplification. So there's already some articles suggesting that MCL1 amplification patient will also be sensitive to sorafenib. So these are the evidence suggesting that perhaps adding sorafenib into this patient's treatment scheme will also help. So our final suggestion is that in addition to everolimus, perhaps sorafenib should be added in order to control MCL1 amplification. So the final treatment option is half dose of everolimus and half dose of sorafenib. And so the patient actually experienced 70% of reduction in tumor mass. And so this kind of suggestion is not just completely based on the pathway analysis. There are already some clinical trial to evaluate sorafenib in breast cancer treatment. So here are all of the prior clinical study showing various degree of efficacy if just using sorafenib alone. And also the treatment dosage and also the toxicity management was also based on this particular study to evaluate a combination of sorafenib and everolimus in patient. And it shows that at least with the dose that was selected, the toxicity is actually acceptable. So based on those information, we provided the information to the oncologist, and luckily the patient is still well maintained right now. So we are following up with this patient's tumor progression. So this is a second example showing that just by adding the information of copy number data, we can add sorafenib into mTOR inhibitor to better control the patient's condition. And then the last example that I'm going to show off is again a metastatic breast cancer case. So this is a patient that initially diagnosed with stage 2B hormone receptor positive tumor, but later on meta to lung, to liver, to brain. And so you can look at the prior therapy. So it's already, this is the 7th line. And so this is the tumor tissue that we get. So this is a sample from lymph node. And so we actually macro dissect out the tumor section. Before we treat before we conduct the sequencing, and the tumor actually show pretty good data DNA quality, and also have very deep sequence. So once we get the data, we are really surprised and actually disappointed because we can detect at least 8 mutations, but none were actionable. But if we look at the copy number alteration, so you can see that here is the 2 copy region. So on this line here, so you can see that this particular tumor has already had a lot of copy number alteration, a lot of deletion on tumor suppressor, but also this patient has some genes that are significantly amplified. Among that is FGFR1, and based on the estimate, there are 9 copies in the tumor. And so although there's no FGFR1 specific inhibitors available at this moment, but we know that some kinase inhibitor have already shown efficacy for FGFR1 positive tumor. So these are the 3 drugs that's available, and 2 of them are available in Taiwan. So based on this information, the doctor decided to choose pazopanib for this patient. So this is the data that was obtained 3 months after pazopanib. You can see the shrinkage in tumor mass in the brain, in the lung, and as well as in the liver. And also all of the blood marker, serum marker, CEA, CA153, and bilirubin was quickly goes down. So we can definitely see the efficacy of this particular treatment just based on the driver mutation in this particular patient. So FGFR1 amplification, is it really that specific for this particular patient? It's actually not that rare. So about 10 to 15% of patients in breast cancer harbor FGFR1 amplification, and the number that we have so far for Taiwanese patients is about 13%. So we just never really look into FGFR1 for the patient. So we know that if we just look at one gene or a particular gene and trying to determine the treatment option for the patient, we probably will miss out a lot of opportunity. If we can at least incorporate most of the information, we'll be able to derive a better solution for the patient. So these are examples that we can use this type of analysis to select treatment for the patient. So again, you go through DNA preparation, you go through NGS sequencing, and then data analysis to produce the clinical report. So how do you get a better information? First of all, if you can perform macro dissection, you can enrich tumor content, then you have a much better chance to detect amplification as well as deletion. So that gives you a much better chance to determine get the option for copy number alteration. And then if you sequence deep enough, then you have a much better sensitivity in detecting mutation. And finally, if you integrate all of the copy number alteration and point mutation data into pathway, then you will probably have a better idea to select a better treatment option for the patient. So this is what we are trying to do. Of course, right now it's still quite early, and most of our patients are later stage patients. But through this clinical experience, we know that one day we should be able to bring this to a lot of patients. And so this is the example. These are the examples that we use NGS to manage patients for treatment selection. The other hope is that perhaps we can also use this cancer-specific mutation to guide patients, to monitor patients' condition, to detect tumor recurrence, and also to perhaps manage the patient. And so I'm just gonna tell you our hope for liquid biopsy is because it can be the patient can be repetitively sampled, and it also reflects the tumor heterogeneity. So our aim is to use liquid biopsy as a monitoring tool for disease control and also to detect resistant variant. And so this is an example that we just saw, that this is a patient who was diagnosed with breast cancer, and again, ER/PR positive, HER2 negative, completed surgery and also 6 cycles of adjuvant chemotherapy, and remained symptoms free until last March. And then but her doctor feel that since we are offering this ECG monitor to monitor patients' tumor-specific DNA in the plasma, so she sent the patient to us for ctDNA analysis. So this particular test is not designed for treatment selection. It is designed to monitor patients' tumor-specific mutation. So it only contains 8 genes, and so these 8 genes cover about 80% of breast cancer patients, and also including ESR1. So those patients who have been maintained tamoxifen, if they develop resistance to tamoxifen, we will be able to detect mutation on ESR1. So this was initial design. And if we look at the Taiwanese patients population, we anticipate this particular panel should cover about 80% of patients. And so when we tested her blood sample, we found that this particular patient has 2 mutations in the blood. One is PIK3, and this is a very different mutation, N345K. And the other mutation is the P53 deletion mutation. Allele frequencies both are very low, so 0.23% and also 1.67%. So with this kind of deep sequencing, this data is we have very high confidence. So we told the oncologist that this patient, we already detected tumor-specific mutation in the blood. So perhaps we should at least follow her more closely. So that was last April, and then when the patient came back, and on her September image data, she still is symptomless, but her tumor marker has already elevated, and on her CT scan, doctor detected multiple tumor liver in the liver, and so this particular ctDNA test actually detect the tumor about 5 months before the CT scan. But since we know that this is a very specific mutation, we have to know, okay, whether this is a druggable mutation. And actually, PIK3 N345K is a gain-of-function mutation. And previous studies has already shown that in the cell line, this kind of mutation could also confer sensitivity to mTOR inhibitor. So at that time, and so if we are talking about pathway, again, it's way above in the PIK3 AKT pathway. But the doctor decided that at that moment, perhaps this is one of the options. So once they detect the mutation, the recurrence in the tumor, the doctor begin to put the patient on everolimus, and so the patient was maintained on everolimus at regular dose, and so on her October and January test, we can see a very clear that a reduction in tumor size and also decrease in tumor marker after 1 month of everolimus treatment. And of course, since this particular assay is designed to monitor patients' mutation, so again, so this is the treatment outcome for the blood marker. But since this is designed to as a monitor tool, so the patient will stand back to us for monitoring. So this was her data from February. So on her February blood, we found that in her blood, the original 2 mutation, PIK3 and also TP53, was significantly increased. So before, at this time point, it was 1.6 and 0.23%. Now in February, it goes up to 32 and 5.4%. So obviously, the tumor is no longer under control, at least not under the control of mTOR inhibitor. So now, doctor decided to switch the patient back to eribulin. And so this is a very, so we are right now following this particular patient. But this is one of our latest example trying to use circulating tumor DNA to monitor, to detect disease recurrence. And for this particular patient, the information detected in the blood can also be used to at least partially select the treatment option for the patient. So we know that for treatment selection, the best sample will still be the tissue. But for monitoring, plasma and liquid biopsy should have a role. And so these are the experience that we have in-house for a few breast cancer patients in Taiwan. And I hope that through our improvement in technology and also accumulating experience, we can make this cutting-edge technology very useful for our patient and for breast cancer management. So this is my last slide. Thanks.